is Jonathan De Los Santos. I'm a physician assistant student at AT Still University. And today's slide presentation is going to be on the pathophysiology of Crohn's disease versus ulcerative colitis. So we'll start with Crohn's disease first. And it's a condition, actually both are a condition that fall into the category of inflammatory bowel diseases. Crohn's is chronic inflammation of the GI tract that most often involves the terminal ileum and the colon. The etiology is unknown, but it's thought to have a strong genetic basis, and cigarette smoking definitely increases the risk, and this is going to be a differentiating factor when comparing Crohn's disease versus chronic ulcerative colitis. I'll let you review the epidemiology of Crohn's, but I did want to point out the bimodal incidence, which makes it a little bit unusual in terms of the peak incidence happening or taking place in a decade of life, and then another in the 5th decade of life. One of the tough things about dealing with Crohn's disease is the fact that initial symptoms may be so nonspecific that it can delay the diagnosis. But when looking at clinical features of Crohn's disease, some of those would be diarrhea, abdominal pain, weight loss. Bleeding is common when the rectum is involved. Fever is going to be involved in 1/3 of the patients, and then in later stages, constipation due to the intestinal narrowing and or fistulas. Pathology of Crohn's is what's really going to differentiate it from chronic ulcerative colitis, and at the end of the presentation, there will be a compare and contrast between the two, but with respect to Crohn's, early pathological changes involve the terminal ileum where there's shallow mucosal defects. There's also transmural inflammation that extends through the entire wall of the intestine. And then Crohn's is well known for skip lesions that affect the mucosa and basically cause it to have a cobblestone appearance. These two photographs depict a couple of the unique features of Crohn's, which include the rubber hosed fibrosis as well as creeping fat on the surface of the serosa. Those are generated as a result of sharply demarcated non-caseating granulomas within the mucosa and submucosa associated with fibrosis of the muscularis and the serosa. This causes the wall to be thickened and rigid. Further pathology includes intestinal narrowing due to fibrosis, adhesions within adjacent intestinal loops and the formation of fistulas, and if there's anal involvement, it's often associated with fissures and abscesses. So moving on to chronic ulcerative colitis, again, it's a condition that falls under inflammatory bowel disease. Again, it's intestinal inflammation of unknown etiology that most often involves the colon. However, in this case, cigarette smoking has been found to be protective, oddly enough. Now, obviously, you're not going to encourage your patients to go out and start smoking. And even if they are smoking, you probably want to encourage them to quit smoking based on all of the other adverse effects it has on their health, not related to chronic ulcerative colitis. However, if they are smoking, it's for whatever reason it's found to be protective in this disease. With respect to the epidemiology of CUC, it's most common between the ages of 15 and 40 years old, with the second peak between the ages of 50 and 80 years old. The clinical features of CUC are bloody diarrhea, tenesmus, abdominal pain is possible in this disease, and if severe, fever, nausea, and weight loss. One of the delineating characteristics of CUC versus Crohn's disease is the fact that it starts its progression with rectal lesion and inflammation, which then spreads proximally, eventually involving the entire colon. Progression of the disease is normally diffuse without involvement of the ileum, and CUC is primarily limited to the mucosa and submucosa. Early lesions appear as flattened edematous patches that involve the entire circumference of the area that's involved. And the mucosa is going to have a sandpaper texture that's very friable and prone to bleeding. These ulcerations will spread through the entire colon and become confluent. Throughout, there will be small remnants of inflamed mucosa that appear to be elevated over the base of the surrounding ulcerations. And these raised areas are termed inflammatory pseudopolyps. If you look at it histologically, the mucosa show atrophy of the crypts with aggregates of lymphocytes in the base of the crypts, which are called crypt abscesses. And this photograph is showing the malignant transformation of pseudopolyps that develop in CUC. So in terms of a PANTS review, the next few slides are showing the differentiation between Crohn's and CUC are what's going to be critical. So number one, Crohn's normally involves the right side of the colon, and the ileum, CUC, normally involves the left side. Crohn's generates skip lesions, where CUC lesions are diffuse, and Crohn's is transmural, where CUC affects the mucosa and the submucosa. Crohn's ulcerations resemble cobblestones, where CUC leaves small patches of uninvolved tissue, creating pseudopolyps. CUC ulcers are broad and more friable, so they tend to bleed. And in Crohn's, transmural inflammation contributes to the thickening of the entire wall with periintestinal fibrosis, adhesions, and fistulas, where CUC's wall is thinner and predisposes the patient to intestinal dilation and toxic megacolon with a chance of perforation. And finally, the risk of cancer is higher in CUC. So I hope you enjoyed this quick presentation. All of the information in the presentation was derived from lectures by Dr. Mark Fiscioni, as well as Shauna Sando, PAC, here at A.T. Still University, the Physician Assistants Program, fall of 2012.